On today's episode, we are talking to cardiologist Dr. Kevin Pistawka and Anne Pistawka, a physiotherapist from Coach. They are married, so they understand matters of the heart in many ways. But today we're talking about cardiac care, your heart, how to optimize, how to know when something's wrong, and where to get help after it happens. You're going to want to listen up. The human heart is a remarkably efficient organ. About the size of your fist, it beats roughly 100,000 times a day, pumping close to 7,000 liters of blood through the body. Every beat depends on two critical systems working together: the plumbing, which delivers oxygen-rich blood through the coronary arteries, and the electrical system, which controls the rhythm that keeps the heart beating in a coordinated way. When something goes wrong in either of those systems, the consequences can be serious. Some problems affect the plumbing, like coronary artery disease, where cholesterol plaques narrow or block the arteries supplying the heart muscle. When that blockage becomes severe, it can cause a heart attack, where part of the heart muscle is starved of oxygen. Other problems affect the electrical system of the heart, causing abnormal rhythms known as arrhythmias, which in some cases can lead to cardiac arrest when the heart suddenly stops pumping effectively. Heart disease is the broad term used to describe these conditions, problems that affect the structure and function of the heart or blood vessels that supply it. Heart disease remains one of the leading causes of illness and death in Canada, affecting millions of people and placing enormous demand on our healthcare system. But it's also one of the areas of medicine where prevention, early detection, and rehabilitation can dramatically change outcomes. Understanding how the heart works and what happens when something goes wrong can help people recognize risks earlier, recover more effectively, and in many cases, avoid serious cardiac events altogether. Anne Pistawka, Executive Director of the Central Okanagan Association for Cardiac Health, or COACH, a community program that helps people living with heart disease recover, rebuild confidence, and adopt heart-healthy lifestyles, is here with us today. Joining Anne is Dr. Kevin Pistawka, a KGH cardiologist and medical director of COACH. Together, they can provide comprehensive insight on the subject of cardiac care, treatment and recovery, medicine and lifestyle, hospital, and community care. They are also longtime friends of the foundation, and it's been a few years since I've seen them both, and so it's so nice to catch up with you guys today. So it's my pleasure to welcome them here today. Welcome, Pistawkas.
Thank you.
Thank you very much. Thanks for having us.
Yes, it's great to see you again. Like I said, we have a long history. Kevin, may I call you Kevin?
Yeah, absolutely.
I mean, I call you Kevin when we're not recording, but you're technically Dr. Pistawka.
No.
Kevin served on our board of directors for 10 years.
For the foundation?
The foundation.
And through all the cardiac, particularly when the cardiac care was expanding here in Kelowna,
Yes.
and we're going through the development of the angioplasty program and the EP electrophysiology program. I felt I was asked to, and I quite enjoyed being on the board for a number of years. And meeting with donors and meeting with other foundation board members and a number of events that all made cardiac care in Kelowna to a greater degree, more possible for a larger number of patients. And,
Yes.
And so, it was nice to be with the foundation during those times.
Yeah, and a little bit of history there, actually. Prior to, I guess it would be about 15 years ago, we didn't have a full cardiac program in Kelowna at Kelowna General Hospital, or even in the interior region. People would have to travel to Vancouver or Victoria, in the case of electrophysiology, for those services. And now, thanks to the energy and the enthusiasm of cardiologists like Dr. Pistawka, we have that angioplasty program here. Plus, we brought electrophysiology here.
Cardiac surgery.
Cardiac surgery. Cardiac surgery was, the Interior Heart and Surgical Center in 2012. So great to have you here. And Anne has also been a good friend of the foundation. We were just chatting about all the fun events that have happened over the years. The Bike and Bri, which is a huge event that the KGH Foundation did for a long time that you guys were a big part of.
A lot of fun being part of that.
Yeah.
It's such an activity focused and the funds raised are always really designated for great efforts and great programs. So we were really always happy to participate in that. It was a lot of fun.
Yeah. And you remember we used to have like every year would come out with like a specialty like jersey.
Oh, yes.
Or
and
what do
we
you
still
call them?
have
I'm not a
them.
cyclist.
A bike jersey or kit, a bike kit.
Yeah.
And we still have a whole collection at home.
The Scottish one.
Yeah, my favorite was the ribs one. The one that looked like
the X-ray image of the ribs.
Yeah, that one was so clever.
Yeah.
Anyway, lots of fun. So, you're both specialists in matters of the heart, and how sweet, you're married. I love that too. How did that happen? Like, how did you both end up? Well, not that how did you get married, but you're welcome to tell that story too. But how did you both end up like in the same specialty, pursuing the same kind of like? There's so many areas of medicine that you could belong to. Why this one?
Maybe I'll start.
Go ahead, yeah.
Well, we met very young and we were at university, and it was both before Kevin was in his medical program, before I was in my physiotherapy program. So we had an interest in healthcare, and then we got into our careers, and our careers, developed in parallel. We moved around. I had worked a lot in acute care in hospital as a physio, so working in intensive care and working on cardiac wards and that area, but kind of separate. Kevin was still doing his training. And then when we came back to Kelowna, that was when Kevin had his first opportunity as a cardiologist. I was busy raising our 4 children, and so my career had really taken a bit of a backseat. But as they grew older, I got back into working more. And it was at a period of time where our community really recognized a need for cardiac rehab. And I had that experience in Vancouver and elsewhere. So it was nice to be able to come and be part of that from the beginning.
Yeah, so we didn't meet in the cardiology world. We, in fact, met. I was a waiter and Anne was a waitress in a restaurant in North Vancouver.
No way.
And and so we evolved. I had to choose my career path, and in Vancouver, I ended up in cardiology, and I actually thought about staying in Vancouver and actually went away and do some cardiac rehab training in Ottawa, thinking I might bring that back to Vancouver, and then we ended up for various reasons here in Kelowna and recognized that it was something that the city didn't have, and through work from a lot of different people, including a physio in town, a kinesiology a grad in town, a few community members. We were able to kind of get, and pharmacy helped out a little bit, and we were able to get kind of coach up and running, and as part of the cardiac package, and it's been going for 30 plus years. So we've paralleled our lives into the cardiac world, but we didn't meet in the cardiac world.
Yeah. Well, you met in the high-paced, high-stakes world of hospitality.
Oh, that's right.
Hey, listen, that's how I met my husband too. It's a great place to meet people. Although I don't know how that works these days. Are you allowed to fraternize work anymore? I don't know, but certainly it was a great place to meet people for sure. What restaurant?
Oh, it was a little restaurant in North Vancouver called the Hobbit House, across from the Capilano Suspension Bridge. Oh, cool. And it used to be an independent restaurant, kind of high-end dining. But this little house that was like a Hobbit house, and that's what it was called. And to get a job there, you actually had to have read The Hobbit, Tolkien's book, The Hobbit, and all of you were tested in your interview of knowing kind of the characters. Like Gollum's
fancy and Baggins cut and all these various things. But
it's no longer there. It's kind of absorbed as part of the Cap Suspension Bridge. And but for a time there, it was a nice restaurant.
Well, if you ever get tired of the cardiac thing, you could open a Hobbit house here in Kelowna. Could you imagine? Yeah. I think it'd be super popular. But I digress.
Yeah.
So Kevin, what drew you to cardiology as a specialty? Because as I said, there's lots of choices.
No.
Yeah, what was it about cardiology?
I think when I went through medicine, I realized I think I knew I wanted to specialize. Much as there's a huge value for family practice. I think I was young getting in, and I said, let's do more. And I think the first division is you have to decide whether you're a physician or a surgeon. Mm-hmm. So in fact, I'm a physician. I am not a cardiac surgeon. Cardiologists are on the medicine side of the cardiac world. And I think what I saw, in my training is that the physicians were stealing a lot of work away from the surgeons because of catheters and scopes. We were basically the physicians were able to take a lot of the therapies that used to involve a scalpel, and now they involved a catheter or endoscopy procedures. These sorts, and a lot of that world was taken over by the physicians. The other thing that kind of drove me is I liked the multitasking aspect of cardiology. Maybe it's like having, working in a restaurant, you got a whole bunch of different tables and tasks on the go. In cardiology, it's not kind of one thing. We have days where we're quiet and predictable in the office. We have emergency days and CCU days are crazy. We have days where we're actually more of a radiologist reading images. We are involved in various clinics, pacer clinics, heart function clinics, and rapid access clinics. So it's a kind of the variety and the multitasking aspect of things. Maybe it's my mild functional ADHD that led me into cardiology.
I love that. And before we started recording, we were talking about the plumbing electrical analogy, which I think is really helpful for people to understand just sort of the basic anatomy of the heart, if you will. But I sort of was going to ask you, like, are you the plumber or are you the electrician? But you had a really unique answer.
No, I'm a general contractor, which actually probably what led me to Kelowna. When I finished with cardiology, I had the option of subspecializing within interventional cardiology or the pure plumbing or electrophysiology, the pure electrical. At that stage, I think we already had 2 kids, and I think it was time to get working. And I actually liked the variety that general cardiology offered, allowing me to spend some time in the cath lab when I came here, time in the echo lab, time in the various clinics. So it was, so yes, I'm a general cardiologist that sees a variety of different cardiac conditions and relies heavily on our excellent subspecialty cardiologists here in Kelowna.
Yeah, which we have great subspecialists here, which is a real testament, I think, to, again, the program that you and your colleagues have built over the last 2 decades. It's very exciting. And your work focuses on cardiac rehabilitation. So some of these discussions that we're having so much more now, thankfully, around prevention and rehabilitation. There's a lot you can do. What led you, you said you're a physio, but what led you kind of to branch off and get into the cardiac specialty?
I think involvement and opportunities that I'd had in my other jobs. I'd had some times where I could actually be involved in some education around cardiac. We had before a coach existed, there was kind of a 1-day cardiac program for people that have been discharged, that have had heart attacks. And it was at KGH in the physio department. And I did have an opportunity with other colleagues, dietitian, physician, OT. We all had an opportunity that day to speak a little bit about prevention. And my area, of course, was a little more mobility, exercise focused, and I really enjoyed that opportunity. And then again, timing, the community was looking at trying to build a cardiac program. So right there, I thought it was a good time for me to be able to transition from working in acute care to working in more clinic-based, where people are kind of out of hospital, ready to make changes and ready to move on to positive things in their lives. And I really enjoyed that part of it. And I've always enjoyed teaching and help facilitating that. And of course, it's something I believe strongly in, even in our lives, is a healthy lifestyle, and then just trying to help promote that where the person's at that time, and helping them to make those changes. So that, I think, was motivation to get out of that acute care and help with that next step.
It feels very, anybody who's ever talked to somebody who's been, I don't know, you call them clients or patients at Coach, will say just amazing things about Coach. It's got such a brilliant reputation here in the community. But we just did an episode a little while ago about aging in place and how important it is as we age to start making good choices when it comes to being proactive about our health. And with our heart disease being I think it's number 2 killer in Canada of people. Well, that sounds really awful when I say it that way, but there is a huge opportunity, I think, on the prevention side, but then also on the rehab side, because just because you've had a cardiac event doesn't necessarily mean that you're doomed forever, right?
Absolutely. And that's what we really try to focus on, is that hope that things will stabilize, things will get better. And heart disease isn't something that just happens and is over. Heart disease, you live with it and you manage it. And that's where Coach comes in, is try to help people manage a little bit better. And that takes into account everything in their lives, their, how they're eating, how their activity is, and also how their connections and wellness, mental wellness are. And so I think that's where we can come in. And another point is that in hospital, it's wonderful, all these new interventions, and everything is happening more efficiently and quicker. And people are passing through, the hospital system very quickly. Yeah. So they're getting their interventions, but then they're getting home quicker. That's great, except for there's less opportunity for teaching in hospital, where a lot of the nurses would have been doing that at bedside, or even the cardiologist would have had the opportunity to speak a little bit more to prevention, but they're just in and out so fast. So that's where Coach can come in and help those people that have gone through that to just digest and unpack what's happened, and then learn how to move forward.
I love that so much. So often we don't have the counterbalance to, we have the specialist or the IST, right? The cardiologist, like Kevin here. And they often talk about how important it is to process that trauma of what just happened, and again, make better choices or different choices moving forward. But we don't have that voice in the room, right? So it's so great to have you. Kevin, I want to kind of get you to take us a little bit through the basics. Take us back to med school. So we use this term heart disease when we talk about heart disease. Everybody's heard heart disease. What are we talking about? What conditions actually are considered heart disease?
Yeah. So I think I'm gonna take you away from actually medical school, and I think because I educate patients quite differently than kind of how I was educated. I was educated with reams and chapters and lots of information.
Good, you can skip all that.
But I try to simplify things. Now, most people, when they think of heart disease, they think of coronary disease, because that's probably half of what we deal with. So that's kind of, where artery builds, or plaque builds up in the arteries, causes increasing obstruction, chest pain and heart attacks. But that isn't the only problem. So I go to car analogies, and I don't know why I do, because I'm not like a real, fancy car guy or anything like that, but I use a lot of car analogies. So so from a car analogy, that's the gas lines. Those are the coronaries are what, feed the engine, but there's a lot of other parts that can break down. And so in cardiologists, we're involved with many of those different parts. So, number one, the car can come off the assembly line with everything hooked up wrong. Well, that's congenital heart disease. So there's pediatric cardiologists that deal with that end, and then adult cardiologists who deal with those patients that have had, many of them had surgeries as infants or kids.
So it's something you're born with.
Something you're born with.
Yeah.
So that's the, congenital aspect. There are also, problems with the valves. So our car has valves that pump up and down a number of times, and there's valves can get narrow, the valves can get leaky. So that we see valvular disease. Then we also see basically heart pump disease. So not all heart muscle pump problems are related to heart attacks. Many of them are, but we see primary heart muscle disease where you basically, start with a 6-cylinder car, and for whatever various reasons, you're down to 4, you're down to 2 cylinders, and you're having a hard time getting up the hills. So that's that's the heart failure world and the heart pump world.
Got it.
And so we see a lot of patients with heart failure because they're not dying of their heart attacks because of the technologies that we have in the cath lab, but they're living longer with heart disease. So we're seeing more pump failure as a result of maybe a multiple heart attacks. And then we see the electrical problems. So your car has a battery and it has distributor caps, and sometimes the wiring goes crazy. It either goes way too slow or way too fast or way too irregular. And so, we have people that deal with the electrical aspects of cardiology. So heart disease, and that's just touching the surface. There's many other genetic abnormalities. There's many other, age-related things. But simply break down, that's the majority of what we see. Those various, electrical valve, pump, and gas line problems.
So I love that. So the heart is the engine, and so there's all these different, aspects of how that functions that could really impact or like could contribute to that engine not functioning optimally.
Right.
Is what you're saying. Huh. Yeah. I didn't know that about heart failure. Now I will always think about my first car putting up Bridge Hill, and that's heart failure.
Actually, we had a car that failed going up to Big White from Vancouver, that we were on 2 cylinders and it finally gave out in Kiramias, and we eventually did make it up to Big White, and that was before we moved to Kelowna. So
but I think it's helpful to think about it in that way, because it gives you a little bit more empathy with what those people must be feeling like. Mm-hmm. You understand. My stepdad lives with heart disease, and he gets tired. Mm-hmm. He gets tired. He can't go 100 miles an hour like he used to. Mm-hmm. So that makes sense. Mm-hmm. And we touched on this in the intro, but I think this is a very common mistake, and I am guilty of it for sure, or I was before we did the electrophysiology campaign, and then I had to learn the difference between a heart attack and cardiac arrest. They're not the same thing.
No, not at all. So first of all, when a cardiologist talks a heart attack, we're really still talking about the coronary arteries. You may have an arrhythmia, atrial fibrillation, but that's not really a heart attack. It's a heart event, but it's not a heart attack. So when cardiologists talk about heart attack, it typically means the heart muscle is dying. Okay. And it's slowly dying because an artery is partially obstructed or totally obstructed. Okay. Now, if you end up in hospital with a heart attack, there's a 95% chance you're going to survive. Because of the technologies and that we have in hospital. So most people present to hospital, they have various symptoms, I think we're probably going to talk about later, and they have the heart attack and they do well and they go home. A cardiac arrest is a death. It's a sudden death that typically happens in the community. And in most communities, 95% of people die. So it's the exact opposite math.
I see.
And in fact, the treatment for cardiac arrest depends the main treatment is get rapid CPR and get access to automated external defibrillators, or AEDs, that you see in the airports, the arenas and whatnot. So cardiac arrest is managed in the short term with that. And then if the patient does survive their death, their sudden death or their cardiac arrest, we then look, what is the underlying cause? We treat that. In some cases, we put in implantable defibrillators to prevent a second event. There are some patients who we perceive to be at high risk for cardiac arrest. And some of those may be in their 20s. So we hear about the football player who goes down and, during the big game or whatever, there are certain conditions that can cause a cardiac arrest that are totally independent to the arteries, that are more of these electrical problems. And they can happen at multiple ages. And so there's some patients where we put in implantable defibrillators because we predict that patient might be at risk for a cardiac arrest.
And then if the heart stops, they
get rebooted. So basically it's like we see the paddles on TV. Yeah. There are implantable devices that deliver a 36 joule shock to the heart and kind of get it back up and running again.
Are you like,
yeah.
Wow.
Yeah.
I'm watching The Pit right now, like everybody else in the world. There's a lot of shocking going on.
And cardiac arrests do occur in the hospital. Yeah. And certainly that's the reason that cardiac units were first developed, is to put patients on heart monitors. That was the sole purpose. Before we had stents and a lot of fancy things, it was put them on a monitor. So if they suddenly die, we can shock them back to life. So certainly there are cardiac arrests that occur in the hospital. And if it is a cardiac cause and they're in a CCU, they generally do pretty well. Whereas if you're at home in your backyard, you don't do so well. So, some cardiac arrests, like I said, there's an overlap. So some cardiac arrests are in the throes of acute heart attack, but not necessarily.
Wow.
And most patients with heart attacks don't suffer a cardiac arrest.
Right.
Most of them don't die.
So the cardiac arrest is basically like a complete seizure of the heart. Like it stops.
Of the body, basically. The heart stops, exactly. Yeah. The heart stops completely. Yeah.
Or it goes
leading to body death as opposed, it's basically multi-system failure as opposed to
blood and oxygen
as opposed to just a portion of the heart. Because you can actually theoretically have a heart attack affecting a very, very small little sub-branch, minute amount of heart damage that is, is a minor blip and really doesn't affect you very functionally.
Right.
So people can have very minimal heart attacks.
Yep.
But cardiac arrest are all big deals.
All serious.
Mm-hmm. How we explain to it in our clinic to our patients too, quite simply, is like one's an electrical problem.
Yes.
And it's like an electrical storm. And that heart beats so rapidly that effectively it can't move the blood through, and so people will go unconscious with that. So but it's rare, it's more rare, but we definitely,
that's the cardiac arrest.
That's the cardiac arrest. And we have survivors of cardiac arrest that have come through our program, and they're always a lot more worried and cautious, like should I exercise? Or quite often if that cardiac arrest happened when they were at a out doing something, and we can give them some guidelines and safety parameters, and usually as Kevin said, like they've been investigated after that as to what caused that and what they can change to help that and prevent that from happening again. And
I have a question with that, but I'm going to park it because I wanted to ask you, and kind of as a follow-up, and I think I probably know the answer based on Kevin's answer, but what are the most common cardiac conditions that you see at Coach?
Well, it's going to be similar. We get referrals from anyone that's come into KGH. Not everyone decides to come, but so we see maybe a little more self-selected group that
is it
have
optional
decided.
Then? Is it
it's an optional. Okay. It's always optional. We can't really force somebody to come along for that kind of thing, but it's offered to as many people as we can that are dealing with heart disease. So we do see quite a few people that have come through the interventional cardiology that have had the stent, had a heart attack, had a stent. Now that flow in the coronary arteries is opened up, and the next stage is prevention.
Right.
Prevent it from happening in any other place, in a different artery or around the same artery, and optimizing all of the risks for that. So that's kind of our focus for those folks. But we do see increasingly more people that have had congestive heart failure and have survived and are really having to manage, oftentimes with more medications than somebody that might have just had a heart attack and recovered from that. And so we have recognized in cardiac rehab world that those folks who are a little bit maybe in lower physically functioning level, they can really benefit from exercise. And so, but there's special parameters around what kind of exercises they should be advised to do, and we can help them with that.
Are they older typically?
Typically they are, but there's a lot of different reasons why that heart muscle might not be working at full tilt and having a difficulty pumping away. And so some of those folks can be on the younger side as well. Sometimes infections, viruses, things like that sometimes happen, and they can affect all different ages. But absolutely most of those folks we see with the congestive heart failure are a little bit on that older side.
It would make sense.
And I think cardiac rehab has evolved as we've realized the benefit. We know that, cardiac rehab, that, it significantly reduces your chance of ending up back in a hospital. It, improves outcomes, mortality. And it used to be kind of a little bit more the old boys club where he was a 70-year-old guy who had bypass surgery, and that's about it.
Yeah.
And now we recognize that there's a lot of different cardiac conditions, not just the coronary disease, that benefit from the education, benefit from the support, benefit from the lifestyle change. So I think we're cardiac rehab started as a pretty narrow little group. There's not too many fields that we see in cardiology that don't benefit from cardiac rehabilitation. So certainly patients with atrial fibrillation, heart failure, cardiac arrest, there's very few cardiac conditions. Even patients that have not yet heart disease but are at high risk. We see some primary prevention with a family physician or the patients themselves, or somebody says, hey, this patient's heading into the cardiac world. Can we do something about it? So we certainly, it's not all about what we call secondary prevention or after the fact. A lot of patients that go through Coach and they say, man, I should have done this 10 years ago.
Right. And I do think I see a very strong trend evolving around, prevention. It's being talked about more. I think just in general, our population is becoming more aware that back in the day, like if you got an injury or, like much like we're talking about an injury to the heart, or if you got an injury to any place in your body, it was like, go home and rest. But now that's not the case. Like we've learned, and I think people are starting to really understand, actually the opposite is what you want to do, is get back to doing things safely, but get moving. Like that's what's going to be more like in alignment with recovery, right?
That's been a trend for the last 50 years.
Oh, good. Well, we're finally, but
nope.
see,
we're catching up.
A long time.
It does, and I find that another difference I see with patients, even in the last 5-10 years, has been that there are more educated coming to coach already. Yeah. Quite often they've already made those changes. They might have quit smoking 10 years ago. They still have had a heart attack or a cardiac problem, but they have already taken those steps. So we really work hard to try to listen to where they're at, meet them where they are, and then give them the trustworthy resources and advice where they're at to make you further changes down the road.
Yeah.
So we are seeing the educational level of everyone is a little bit more, thanks to campaigns from Heart and Stroke Foundation and just knowledge of in schools, and people are understanding that.
Well, and I think
it makes a difference.
I mean, we like to disparage social media so much, but I do think that it really has helped to popularize being empowered around making your own decisions around your health, right? I also just, this is, again, I don't have data in front of me to support this, but we're starting to really understand how obesity in itself can impact so many other things, right? And I think people are generally trying to be more healthy. I mean, back in the day, everybody smoked cigarettes. Can you imagine? Like, that's not a thing anymore. I mean, I guess it's a thing.
It's
still a thing.
I know.
It's still a thing. It's amazing.
But you look, we all have kids that are in their, 20. I have kids in my 20s. You have kids that are around that same age. And like that generation doesn't smoke cigarettes. I mean, I'm sure there are people that do bad things too, but we've learned some things over the last couple of decades and changed behaviors fairly quickly, which is a good thing. I want to this conversation is flying by, and I want to get some information out there about, because this is really important for our audience to understand. Kevin, I'm going to ask you, when someone is experiencing a heart attack, what symptoms what symptoms should they start paying attention to? And then what symptoms are bringing them to the hospital? Because I recognize that maybe they're having symptoms before they even think they're symptoms. And then they have something dramatic happen and decide it's time to go to the hospital.
Yeah. This is a tough one for, patients and physicians. Number one, over half of patients that actually have a heart attack have no preceding symptoms apart from the 24 hours prior to their event.
Really?
So many of them, and this is because many heart attacks are a sudden rupture of a coronary plaque, a plaque that's been minimally obstructive, now is partially obstructive or totally obstructive. And so, patients don't have warnings. The ones that do will typically say they've had symptoms with activity in the top half of their body. Now that can mean their jaw, their chest. It could be, typical tightness where they clench their fist in front of their sternum. It can be heartburn. It can be shoulder pain. It can be forearm pain. It can be pain between the shoulder blades. But patients that have the really, warning signs that they should listen to is, I used to be able to walk up, the 16th hole of the golf course or Knox, but I get halfway up and I get this sensation that feels very uncomfortable for 3 or 4 minutes. It goes away. And if that starts happening, predictably in a crescendo sort of pattern, that's a bad sign. When patients present to emergency, it's very difficult because, some of it is overlapped with heartburn and gastric stuff. Some of it is overlapped with anxiety and panic, panic disorders. And so there's all sorts of, reasons that patients can have. But if the gist is, if you think you're having a heart attack and you have persistent symptoms that are making you feel really unwell, particularly if you're sweaty and short of breath, get it checked out.
Wait.
Don't dismiss it. We're pretty good now getting patients in and out of emergency to know whether they have a heart attack. We have good enzymes detectors now. We used to send people home with heart attacks because we thought it was indigestion. Now we actually have pretty good tests to triage and sort out who's at very low risk, who's at medium risk and should be seen in a week or two, and who's at very high risk and needs to come into hospital.
Mm-hmm. Yeah, and it's very true. We've been learning more even on this podcast about some of the tests that are available that can indicate whether someone is imminently going to be having a heart attack. And are there differences? Are there differences? I think I know the answer to this one as well too, but between how heart disease presents in women versus men.
Yes, definitely. There are, and there's been more research done on this.
Yeah.
Thankfully in the last little while, back in the days of the many of the early studies, it was really just on men and really wasn't recognized as something that could happen to women. There are a few distinct differences. One of the biggest ones is that women tend to present with coronary disease or heart attack about 10 years later than men. So a little bit later delayed. So they're older.
Yeah.
Whereas you sort of averagely take 65, 70 for a man, it's maybe 75, for a woman. So they have other conditions too by that time, So sometimes it's a little harder to straighten out whether this is, chest pain from or pain from heart attack or from something else. So women too tend to also not really jump to that thought that, oh, this could be a heart attack. Whereas I think men, that might be with any symptoms, that might be top of the mind. That's changing. Women are becoming a little bit more aware of that. But women will tend to sort of maybe belittle their symptoms and, oh, they're not, that little bit of change is just age. Men do this too, but I think on the whole, it's been shown women have done this, and so that can prevent them from getting in. So I think now we're getting a little bit more of the message out that women are certainly at risk, as high risk as men, just presenting a little bit later.
Yes.
And their symptoms might not be the typical elephant on the chest kind of pressure, They might have back pain or other kind of presentations. But again, that was what Kevin said, if they notice a change in their ability to do what they've normally done, that's kind of dramatic. Those can be a little bit warning signs.
Yeah.
Of something.
I know you're not an endocrinologist, but do you think that, you are a woman, do you think hormone, like estrogen, we've sort of been hearing a lot more about, I know this wasn't on my list, but like estrogen may have like more of a protective effect for the heart, and then once menopause hits, again, that could correlate with that risk?
I think that it is interesting to think that, women are, why is it that they're 10 years later? And you can think, well, that's sort of postmenopausal. Yeah. And so there may be a link, but we know giving exogenous estrogens has its own risk as well. Kevin could speak to that more on the medical side of things, but it's not so simple as, let's just replace this and we can prevent, heart attacks. So I think it's a little more complex than that.
Yeah.
But we don't fully understand exactly why there may be those differences.
And it's a bit of everything. I think it's like, is it our testosterone or is it her estrogen that makes the difference?
Right, yeah.
And so there are effects on lipids, there are effects on blood pressure. Men's behavior are different. For the longest time, men were the main smokers, and then women decided to catch up. So there's many things that led to heart disease being more prevalent in men.
Yeah.
I think you talked about obesity, diabetes. I think we're sort of seeing that those aren't as sex gender specific. I think that both genders have issues with there as far as risk factors. But there's certainly aspects. But I think the gap has narrowed a little bit.
Yeah.
I think we're seeing younger women with certain cardiac conditions, and we're seeing older guys.
Younger men too. Yeah,
that has been a trend in cardiac rehabilitation too. Is women are now attending, which before they didn't tend to as much, and
because I think it's that still there's still this. I don't think it's a fallacy. I think, to your point, perhaps this was a more of a man problem before, but now we're starting to realize, and I guess the point is that it is not gender specific, that there are that women are experiencing heart disease as well as men, and that not to just bucket it off and be like, oh, that's like more of a man thing, like I can worry about something else, right?
And they can participate and actually benefit from attending or getting treatment and then attending rehab too.
I totally agree. Kevin, one condition I seem to be hearing more and more about is, and you've mentioned it, like atrial fibrillation. Fibrillation. We're going to put that one on one of the words that I can't say, or AFib.
AFib. Yeah.
Are you seeing that more? What is that, and what are you seeing it more in your clinical practice? What's maybe driving that?
Yeah. So atrial fibrillation is where the upper chamber, one of the chambers, usually the left atrium, gets stressed out for various reasons, high blood pressure, alcohol, age, and leads the heart rhythm to go into it. Instead of its nice regular cadence, goes into a very irregular, usually fast cadence, and that causes all sorts of symptoms. Sometimes no symptoms at all. Sometimes it can cause patients to feel anxious, palpitations, short of breath, chest discomfort, and can lead to strokes, because when the atrium's fluttering around like a bag of worms, clots can form. So atrial fib is a big deal, and I'll probably see in a clinic maybe 5 to 10 patients a day who have atrial fib. So it's super common. Now, as far as why that, partly it's longevity. So the biggest risk factor for atrial fibrillation is living long. So if you don't die of cancer, you're probably going to get atrial fib. You live long enough, you're probably going to get atrial fib. So certainly 5% of people over 65 develop it. And if you get to 90, many patients have it. So that's part of the thing. Probably atrial fib, it is highly driven by excess weight. And we're seeing more of that in North America and around the world. And that's often because of an influence on weight and blood pressure. Mm-hmm. So high blood pressure is a very common cause. Sleep apnea is a cause that's partly related to weight. And then some of the atrial fib we're seeing is just because we're detecting it now. 30 years ago, we didn't know what that was. We weren't all wearing monitors. So now everybody's got Fitbits and Apple Watches, and you go to the gym and your treadmill, your elliptical will give you your heart rate. So we're now finding atrial fib that we may not have detected before. And some of that actually doesn't pose the same risk, and it isn't exactly the same as the patients that are having, days or months or years of atrial fibrillation come into emergency to get the heart rebooted. So it is a little bit different disease, but we're certainly seeing lots and lots of atrial fib.
That's interesting. I never thought about the connection between the wearable technology, right? Because you start to become, I decided I'm not going to wear my Apple Watch today, even though I normally do.
I don't have one.
I'm trying to
guilty.
Yeah, I have one, and I actually one of my resolutions this year is I was going to stop optimizing every data point of my life. So it was a practice for me to not wear it but the thing is, when you do wear them, you start to become quite knowledgeable about what your resting heart rate is, for example, or if your heart rate goes up, you can just immediately look and see oh yeah, no, I'm not, that's actually happening right now. So I never thought about it that way. Okay, so I also mentioned that I'm watching The Pit like everybody else in the world right now. Did you guys watch it?
No.
It's too much just like watching a day at work.
I know. I wonder that. It's so great for me because we work sort of on the periphery of healthcare. We're very close, but not quite in it. Yeah. So to see, the equipment like the Lucas, which is something we funded, in action, or whatever it is in action on that show. It feels very real. But anyway, one of the things you hear on that show a lot is code STEMI. And we hear that a lot here at the hospital. So what is a code STEMI?
Okay. So so code STEMI. So the STEMI stands for ST elevation MI, or myocardial infarction. So on an ECG, patients having small heart attacks, we might not see much, but the big ones, when an artery, a particular bigger artery, is blocked off completely, we will see a certain segment of the ECG that we've all seen the spike of an electrocardiogram. Yeah. We will see this ST elevation. And if we see that, that's a bad problem. Patients they're losing heart muscle. And we know the term is kind of time is muscle. And you've got about 12 hours to open up that artery, or everything beyond that it's lost. It's completely dead. So there's an urgency to this, an emergency to it. And we even talk about the door to balloon time. So the aim for a code STEMI is to get the artery opened up really quickly. Now, if the patient happens to arrive during the day, great. If the patient arrives at 2 a.m, the code STEMI actually goes out to 4 or 5 people sleeping in their beds in Kelowna. And they actually rush in. That'd be X-ray techs, nurses, physicians come in, and we aim to have the kind of door to balloon less than 90 minutes. Now we're actually having patients have ECGs in the field. So in fact, the ambulance guys, paramedics,
also funded by the KGH Foundation,
are often alerting the cath lab. And some patients are bypassing emergency. They're not even going into the emergency room. They're going directly from the field to the cath lab.
Yeah.
And our sphere of influence in the Okanagan used to be Kelowna, but now we're getting better at it. So we sort of said, hey, let's do West Kelowna, let's do Peachland. Hey, we're now doing Penticton and Vernon. So we're able to offer that service to a wider percentage. In the previous days, we used to have clot busters. So the rural communities, Cranbrook Trail, Kamloops, they still give clot busters as their STEMI treatment. And kind of keep their fingers crossed and hope that the artery opens up. Yeah. It works 90% of the time. It's not quite as effective as opening artery up emergently with a balloon, where it's a little lower risk. But so code STEMI usually means, hey, the team get that patient onto the table, get that artery open up. Unfortunately, we have 4 individuals in our group, and all the cath lab team that are really good at doing their job.
Yeah, amazing. Thank you, because for those of us that like that show, I think we're lucky we're not in Pittsburgh, because they have a code STEMI like every 10 minutes somebody is STEMIing. And as you say, and this is one thing I do know, because the KGH Foundation has had a lot of opportunities to work with the cardiology department over the years and funding various things. But so we've done a lot of work with outfitting the cath lab to help with those code STEMIs. As you said, the ECGs and ambulances was another really successful donor-funded program. So we know that code STEMI is a big deal.
I was going to add, Kevin, you should maybe talk about non-STEMIs.
Yeah,
because
I think that was the next question.
That was
the next question.
Oh, perhaps.
Okay.
Sorry.
Well,
I just to give the context
give it context.
of where they
non-STEMI. Okay.
Just
your general run-of-the-mill.
So a non-STEMI is a patient who's still is having a heart attack, but usually the artery is not completely occluded. There's trickles of blood going through the arteries, keeping that muscle alive. So that's a less dramatic presentation. Mm-hmm. And usually we detect that actually because of blood tests and electrocardiogram and because of the history. And so patient will come into emergency, and we will, through our various testing, kind of know that they're at increased risk. But that risk isn't I need to deal with this minute risk. This is I need to deal with this kind of in the next 48 hours type of risk. So the patient's journey would often be less urgent. They will still be admitted to hospital. Yeah. They'll still be given medications to prevent the artery from blocking off completely. They will still usually end up in the cath lab, to take some pictures of the arteries, and then they're stratified. Some of those patients, we might find their arteries are normal. There's something else going on. We may be wrong with our non-STEMI diagnosis.
Right.
We might find that they've got some artery disease. It's just best suited to medications. We might find there's an artery or two that needs stenting, and we'll do that at the same time. Mm-hmm. And we might find, oh boy, you're really plugged up. Doing multiple stents won't be as effective in the long term, particularly for diabetics. So those patients need bypass surgery.
Right.
So some of those patients are triaged, and that will be done in a urgent fashion, but not in emergent fashion. So non-STEMIs are a little less emergent. And we have many patients, unfortunately, sitting out kind of in Cranbrook and Princeton with their non-STEMIs waiting to get a bed in KGH. So they don't all come rushing in a helicopter.
Mm-hmm. And I'm glad you say that, because it actually makes me think I haven't done you two a solid, because I literally need 2 hours for this podcast because cardiology is not not that I don't want to say, oh, the stroke guys is so easy because it's just like a clot in the brain and away you go, suck it out and da-da-da. But it's very nuanced, as you just said, as is most of healthcare. Yeah. And that the spectrum of what a heart attack is, STEMI being the most urgent and emergent, right? But then you can, as you said, some people, my stepdad, case in point, they told him that he was having a heart attack probably long before he ever came into the hospital, because of what you said, is that it's not a full blockage, but it's compromised.
Yes. And usually you need kind of 95% narrowed. And the patients, like I said, they
then they're
get
starting to be like, ugh.
And they get their trim, usually starting to have patients having symptoms at rest, not just with activity.
Right.
And then once they get into hospital, most patients with non-STEMIs and STEMIs actually do very well. And they spend hospital usually only a couple of days. They might get an ultrasound to assess the heart pump function. They'll see the team. They'll see our nurse practitioners. They'll see the pharmacist. They'll see, the nursing. And then boom, they're out of there pretty darn quick.
Yeah.
And then it's time for follow-up in both the cardiology or internal medicine offices, GP's offices, and importantly to cardiac rehab, either kind of live or virtually.
Yeah. Well, that's a great transition. I'm gonna ping pong back to you, Anne, because this is where programs like Coach become incredibly important. So what exactly is what is Coach? Like, what is your mission, and who is it designed to help? I mean, we've talked a little bit about it, but I kind of want to get you to give the whole mission statement, and who are you helping? What are the services that you're providing?
So Coach offers the cardiac rehabilitation programs, which under that umbrella, we're really trying to help people manage and optimize their risk for heart disease. Prevention is a huge aspect of that moving forward. So the aim really is to help arm people with information to know about their disease, understand what's happened, unpack what has actually happened for them, and then also point them in the direction of that healthy lifestyle. So making those small habit changes that can involve diet, that can involve exercise, which is a big part of the Coach program, and it can involve medications that help them. And we help to, foster kind of that adherence to the regimes that we know, work from evidence-based. And so over time, that's really the crux of cardiac rehab. And for different people, it can take different forms. As I said, we meet them where they're at. So some people really have already a good habit of exercise. They may just need a little bit of pieces of information to help them stay on that track or point them in the right direction and guidance. Others, it's all new for them and they have many changes to make, and we may take a little longer to do that. I always look at it 2 arms. We have that educational arm and resource arm, and then the actual monitoring exercise. So we have people in clinic where we will be having them start an exercise program. We'll monitor their vitals, their blood pressure, their heart rate, give them that feedback to then be able to design a good program for them so they have more confidence to exercise. And then at the same time, they're receiving some of this information that can kind of fill in the blanks.
So it's personalized almost
very
to
much
their specific needs. And if I'm understanding you correctly, you have the equipment, the testing equipment at Coach that can allow you to sort of like tweak and optimize those, if we're just talking about exercise, for example, those programs. Because I'm thinking like, I guess you can't tell me like, oh, what are the best things people can do? Obviously we're not trying to replace Coach with this podcast, but for anybody listening that may not have gone to Coach or gone to Coach yet, and is wondering like, what are some of the things I can be doing? Are there things like, let's talk about exercise that like just in general are like heart healthy?
Yeah, in a nutshell, it can be pretty simple, really. What we want to do is make sure that people get about that 150 minutes per week.
150 minutes, okay.
So if you think about that,
2 hours and
it's probably around 30 minutes most days of the week, 5 to 7 days of the week. That's how I break it down. And you want to get into a zone of exercise that's continuous, that you can feel you're in a steady state and you get that breath going, but you feel comfortable and you can talk. That's where the talk test. And that can take many forms for many different people. Some people just enjoy walking, and that's great. And if people are walking regularly, they'll find over time that walking on the flats gets too easy. They need a hill to kind of get that feeling. So those are the things we try to help personalize. Some people like to use machines, and be in a gym and do that.
Stationary bike.
So any of those aerobic activity machines in the gym are going to do the trick. So it's really just not one better way to do it. It's anything that you can do that you enjoy, that you can sustain and get that feeling of moderate exercise where you're in a steady state, where you can feel the breath, you can feel the rhythm, and you can continue that without feeling like, oh, I've got to stop, within 5 minutes. You want to be able to feel that moderate zone, and doing that regularly. every, doing that 5 days a week is
Can we just make
key.
a rule or make this is what I like to do. If you can aim for 30 minutes a day, that's a pretty good start.
And it doesn't have to be
What if it's somebody
vigorous?
that's never done anything? No, I shouldn't say that. Like, I have someone in my life who I love very much that just hates exercise so much. But this person knows that they need to do it, but nothing is fun.
Now you're getting into the real nitty gritty, the
That's
motivation
right.
and
Yes.
building habits.
That
is exactly, it's easy to say, okay, you need to get this. Everybody kind of knows that they should exercise more. It's how do you go about that?
Yeah.
And then for those folks that have had a heart attack or had cardiac event, they're more scared. They really need that guidance. But we start where they're at, like 10 minutes, and in little intervals and build. And again, I can't emphasize more. It's the habit of it. Yeah. It's not important what you do or how intense you do it. It's that you do something and you start somewhere and you try to build that as time goes out. And finding something enjoyable and maybe with community, that can really help you stick to it. Mm-hmm. And rather than being just a slave to a machine because you think, oh, this is the best way. Mm-hmm. There's many, many different things activities that you can do that would be heart healthy. Yeah.
And is there and I try to think about it in those terms too. Like for me, I love exercise. That's not a hard thing for me to say, oh yeah, I could totally do that. But recognizing for so many people, it's just not that fun.
No, and you have to add in like lots of people as you age, you have other problems. You might have back problems. You might have knee problems and hip problems. Many of our clients have had joint replacements and you work around that. And that's why, you've really got to figure out what works for you and what's enjoyable for you and what's possible for you. But your body responds to any kind of activity the same way. No matter what activity it is, you start breathing a little heavier, you start getting a little warmer, you get into a zone. It doesn't matter which activity you do as long as you can get your body into that. As far as the heart goes, we also work on strength and conditioning, some of those things as well. Become a secondary factor and goal for building a healthy life too.
Yeah, and I was going to ask you about the strength because that's been something we hear a lot from other clinicians, just talking about how strength training programs can really benefit and optimize a person's longevity, right? But then I think if I have a heart condition, like I don't know if I want to be straining do you know what I mean? That muscle that way.
Yeah. And I think, part of going back and resuming some of those things is step by step, break it down, start small, see how you feel. And then eventually people are able often to get back to regimes that they were doing before, but it's peeling back. And I always sort of think use the brain muscle before you attempt to start designing your own program.
Right.
It's like break it down, see what works for you. And if you've had a cardiac event, you definitely want to take care that you're not doing some of those things, straining where the blood pressure would go up really rapidly and fast. And I think for a lot of our clients' patients, they are just adjusting to new medications too. And so that can affect kind of how that exercise goes. So being patient with yourself, sticking to it, and knowing that even a little change, even a little bit more is going to be beneficial. And pretty soon after a couple of weeks of people starting, even if they're doing that 10-minute intervals, and they feel better. They do feel better. And then we just help to encourage them to focus on that they're feeling better. Let's carry on. Let's continue on. And so that's how we kind of build it. And we can serve people that live within the area that can get to our coach clinic. But for those that can't, we've got the cardiac services in Kelowna at the hospital at KGH. They serve everybody in the interior health region. And so we have many patients go back to the Kootenays and to Williams Lake or
Fort St. John, Fort St. James. I mean,
and so those folks we can reach with some of the resources. But
and the exercise has to be kind of accessible. So, and that can be difficult. And there is certainly still quite a significant rural-urban divide for heart health. We see the difference between the patients in Fort St. John and Prince George. And so, it's hard to go out and say, do exercise if there's grizzlies in your backyard or there's 3 feet of snow always. So
totally.
It is more challenging. And I think, But what's interesting is that, even 15 years ago, I remember going to a conference, and it was first talking about cardiac prevention, not at such an individual level, but very, very much at a community level. And how do we design our cities? And how do we decide, what do we have in this city that can promote that? And that can happen it certainly happened in Kelowna. We see the rail trail and the greenway and those sorts of things. And smaller communities have opportunities to grab onto some of that. It's harder. It's more challenging when there's only 1,000 people living in your town. But it is very harder. But I think cardiac prevention involves, it's not just an individual thing. It's very much a community thing as well.
I love that you say that, because we, one of the reasons why we've named this podcast the Wealthy Podcast is because we take this very integrated, holistic view of health in general, and that is that it's not just physical health. We're not just talking about, illness or broken bones, but we're talking about the whole spectrum. So it's physical, emotional, mental, spiritual, and community is a huge part of that, right? There's a role to play.
We learned this in New Zealand. We both worked in New Zealand for a year and a half before, we did some of the training in Vancouver, and you actually saw the Maori population. They look at health in a very different way. It's not just about my individual health. It's the health of my partner, the health of my family, the health of my relatives, the health of the Maori community, and extended. So they look at health in my spiritual health, my emotional health, not just kind of do my knees hurt. And it is a very much more holistic way. And I think the way the world's going these days, we all realize what an impact changes in your world, your country, your community can have on your well-being.
Absolutely.
And so I think it's really important that we don't that we individualize and focus on health as only medicine, as it is manufactured in hospitals and clinics. You need to look at all those aspects of health. I'm glad your podcast has been able to explore those questions.
I'll just add, from my world in cardiac rehab, we're really trying to help people gain some confidence around their bodies and what they're doing with it, and getting those healthy habits, and then making connections in that next stage for a long life. So making those community connections. And I love in our community that we've got the YMCA have done a terrific job at providing those areas where people can stream into programs. They have healthy heart programs as well.
COPD,
there's a lot.
Also funded by the KJ.
So
it's like shameless plug day here on the Wealthy Podcast.
It's like this long continuum, right? Of having just that support and opportunity for people to be able to participate and continue.
I love that you brought up the Y.
Yeah, they are a good partner of ours, as well as lots of other programs and gyms and Parkinson Rec Center, and shout out to Johnson Bentley. They all have these facilities that people can access relatively easily.
And fairly cost effectively as well. Not
too many barriers, and so for those folks that like to be in those groups and connections, it's fantastic. We have another little plug. We have a maintenance program we call the Kelowna Cardiac Exercise Society. So it sort of functions just alongside of Coach, but it's more long-term, forever exercise, and it works out of the MNP building using the indoor track. So people will walk on the track. They'll also be led with some strength exercises 3 times a week. And it's just, some folks have been going for 20 years to that. And they just really feel connected and strong. That's helping their health. So those are the things that we're really trying to build, those seeds, I think, in Coach, and encouraging other communities to be able to do the same.
The Pritchards have been longtime members. And the foundation and the hospital and the university all know those folks.
Yes. And you know what? I love that you guys are connecting the dots, because sometimes we tend to focus sort of on the acute care aspect, right? And just having you two here is so great, because obviously when you have an acute incident, it needs to be managed and it needs to be treated. But then there's the aftercare, and then there's the prevention, but then there's also the community supports. So it's like this fan of first you have sort of the acute, and then you have the recovery and learning about the lifestyle. But then you're not alone after that either. There are supports in the community. I love that you mentioned the Y. They just do such a great job in our community at offering programs for all ages and stages to optimize their health and meet them where they're at, which is really, really such a valuable asset to our community. And as you said, there's others out there. So I can't even believe this hour has gone by so fast. Didn't get to my I got to a lot of them, but not all of them. And I'm sorry for that because you guys are so well prepared. But I want to wrap up just kind of with some sort of future forward questions and then just some reflection. So maybe Anne, what excites you the most about the future of cardiac care in our community?
I think that more people are surviving, and they're also the interventions are becoming a little less invasive for them. So it's a little easier for them to access and transition through that. And they're a little bit more ready for the information to come and make some of those changes. So it's very hopeful. And we've had some great, the patients that come through that have gone through and then turn around and say, this has been great for me.
Yeah.
It's really set me on the right course. And that just makes us at our clinic with our, we have fantastic staff that are there, exercise physiologists, RNs, and just support them. And they really have learned something and they can take that forward. So I'm always hopeful that people can make changes. They can actually have a little bit of control over their health. And they're able, when you see that actually happening, I think that's a very positive thing. And we hope that for everybody that goes through and doesn't feel alone or that they can never do the things they want to do. And at the end of the day, it's about quality of life and being able to really manage well.
I love that.
That's kind of hopeful for me, I guess.
That's
so it's really,
hopeful.
It's not anything, as far as future that we're going to have these amazing techniques. They're all really good, but at the end of the day,
the robots aren't going to come and
right.
take over our heart function for us. Or,
at the end of the day, people always have hope and they can, and sometimes it takes a little time to find that for them.
Totally. Kevin, do you have anything to add to that?
Yeah, no, I'm optimistic in the future. I mean, future cardiology. I think there's going to be a manpower issue with cardiology, and I think we're seeing the benefits of a team approach. So we're going to see more and more nurse practitioners, associate physicians, physician helpers, various people, and pharmacy help that. Pharmacy already do. That's probably why I didn't include them. They're a huge support. We have pharmacists comes and does rounds with us, but we'll see that. AI is changing a little bit of what we do, and I don't think it's going to probably replace all our jobs, but it's going to help our jobs. We're using some of it in the office already for our notes, but increasingly it's going to help with, imaging as far as interpretation of imaging. We still probably have to oversee, but it'll make it probably a little bit easier.
Faster, maybe.
Yeah, we're probably going to get better at individualizing care. A lot of cardiology prevention, we're treating populations because we're not very good at knowing who exactly is going to be the one that goes down with a heart attack. We're not, the whole business of who's got the vulnerable plaque. Preventative angioplasty doesn't work. So people find, I need to find my blockage. That doesn't work. So we have to have a better job of right now we actually treat populations for cholesterol, for high blood pressure, for diabetes. We treat a whole bunch of people to prevent a whole bunch of events. But with precision medicine, we might get better at that, and so that we can deliver the therapies to those that really, really need it the most, and maybe deliver new therapies that are, again, genetic therapies, through the whole RNA thing, that there may be new genetic modification, whether you want that or not, good, but that's a societal decision. But we're going to see that, and we're going to see, more and more telemedicine. So we're with COVID, that's probably one of the biggest booms of COVID, is that we started doing a lot of stuff over the phone. People didn't have to drive 8 hours from Invermere or whatever to come here. So I think we'll see expansion of telehealth delivery, and who knows, maybe there might be some, again, AI deliverer of care. I think it's a scary world and an exciting world at the same time. So it'll be interesting to see how cardiac care evolves. But I think there's going to be lots of stuff coming up in my my younger partner's worlds is going to look very, very different 20 years from now.
We had Dr. Koutsinos on a couple podcasts ago. He is a thoracic surgeon here, and he was talking about Vinny, the robotic assisted surgical program. And it's funny because I do think that there is, to your point, like, or maybe to my point, is there's a little bit of trepidation when it comes to AI and technology in healthcare, because actually we don't want to replace people in healthcare with robots. I say that like lovingly, but it's true. Like,
you should have a social contract. There should be, people should want to get up and work and not just have all the wealth in a few people's hands.
And then honestly, when I had breast cancer in 2019, and I didn't want to. I needed to talk to a person. Yeah. Do you know what I mean? Even though all of that information may be in the future available through a report or through an app or something, we're not ready for that yet. And I do think, and Dr. Koutsinos did a great job in just sharing how this technology optimizes what people can do and not necessarily like replaces them.
It's a good example of that in our program, when we talk about resources. We broadcast our educational program out to these regions that are more rural, but it's still a live person. Yeah. So it's still, we could package that and just have but this offers a chance to have questions asked. It stays relevant with each broadcast. So every week we're having that live, and I think people really appreciate that connection. Yeah. And we're using technology, but we're still keeping that human element that allows for that. So.
And to Kevin's point about, like, I always talk about the sample size of one, the population data and metrics and all of that, and like being able to optimize to broadcast to large groups is great. You can use technology for that. But at the end of the day, it's still about one person's journey, right? And I think nobody is ready to let go of that. And this technology might be able to give us more access into that level of personalization that is going to take us to the next level, rather than the robots coming and taking over the human elements of healthcare that we all really appreciate. Okay, this has just been such a great conversation. I feel like there's still so much more we can cover, so I might just have to have you guys back. I want to just close. I'm going to ask you as the same question, but I'm going to challenge you to answer it differently. So we've talked about this being the Wealthy podcast, and that wealthy really translates for us that health is wealth, but that, as we've discussed, health is multifaceted. It's not just like, the absence of disease or injury. In a sense, it's a proxy for abundance. I'll start with you, Anne. I'll make it harder for Kevin. In what areas of your life do you feel wealthy or abundant?
Oh, I feel very blessed. I guess initially when I think of that, I think of the people around me. So connections, my family, and we're blessed to have children in our lives. We're expecting our first grandchild.
So
very exciting. So family, and that is obviously connection. But beyond that, our personal health, I feel really lucky. We've had ups and downs, both of us, with injuries and issues. But we're able to do a lot. We're still very thankful we can participate in a lot of the things we love to do, activities that we like to do. Yeah. And so I'm thankful for that. And it's something you just can't take for granted, and continue to work at that, especially as you age. Look forward to the abundance I feel is for my health and what I can do. And then the connections around me that are great. And the work that I do, I really love I love doing what I do because I work with people, and people that are making those changes, and I have a great team to work with. So that for me is my abundant life. That. Yeah, you can talk more about the activities that we do, Kevin. I really enjoy doing fun.
Took a lot of the good
that's okay.
Okay,
I can still talk. I can still talk. No, I feel pretty blessed with a lot of things as well. I moved around a lot as a kid. I ended up in Vancouver, and kind of when people said, "Hey, you're going to Kelowna," they're just like, "Why are you going to this little hick town?" And I feel pretty darn blessed. We ended up here, and I was able to be on the journey that has been the development of cardiac care here,
Yes.
but also take advantage of our community, all the lifestyle that we've had for our kids. We've all been soccer players and hockey players, and we've been able to coach or assistant coach and trainers on various teams. The skiing's so accessible.
The water skiing.
We like the food, we like the wine, we like the industry, and we like our community, and we've been able to really tap into and make some really great friends, both medical and non-medical, in this community. That has been such a bonus. And I think as we age, we recognize that we're gonna have health issues, and we're kind of recognize that many people move to the Okanagan because we've got the resources. And I think I'm blessed not only that I moved here for my career, and we did for our kids, and we've had a great life, but we're pretty blessed that if we stay here, we're going to get great access to care. And it's because of a lot of different people along the way, including the foundation, who have helped kind of things really, really explode. So I feel blessed that we are somehow, I don't know, partly it was choice, but partly it was just circumstance that we ended up here, because I think from a cardiac perspective, it ticks a lot of the boxes being here in the Okanagan.
Oh, I couldn't agree more. Both of you have provided such a great summary for those of us who live here. Some of the, I always think sometimes our podcast can be like advertisements for why Kelowna is the Central Okanagan is such a great place to live. But it's the first time somebody said, I feel blessed because we have great healthcare here. We do. And part of what we're trying to do with this podcast is like counter the narratives that in the mainstream media that tend to just focus on what's not working, but there are so many things that are going right. And I hope that people listening to this podcast on a regular basis feel, like you said, Anne, like some hope, like, sure, there's a lot of things that we need to continue to keep our eye on the ball, and there's a lot of things that are going right, and for those things we can be grateful. So good job, you answered those you answered those questions very well. And you know what, it's just been such a pleasure speaking to both of you. I've worked with both of you in various capacities over the years on foundation stuff, and you've always been such a delight. But this, being able to talk to you more intimately about the work that you're doing and the impact that you're having on patients' lives in the community and, within the scope of your practice, is just like really a treat. So thank you for joining us.
Thank you for having us.
Thank you very much for having us.
Thanks again for the foundation for everything they do here. That's great.